Yes.
Perfect. For those of you who don't know me, I'm Rachel. Rachel Wallmeyer. I'm the program director here at ECMC. Just wanted to give some housekeeping updates and whatnot, so you guys know what was going on in the last week or two and what's coming up in the future. So this past weekend was our annual murder mystery fundraiser for metastatic research. We raised about $5,000 at the event. And we announced our donation for the previous year, which is going to be a donation of $18,000 to Roswell Park's triple negative metastatic breast cancer research project. Everybody who participated or shared the event and participated in any capacity. So that's really exciting. And upcoming this weekend actually is our level 1 Reiki training. It's actually filled up all the way. It's at capacity. There's no more room as of now. If you're interested, send me an email and I'll add you to my wait list, but it is Saturday. If you want to look at the info for that, the table right around the corner has flyers if you're interested. Our next day of removal is going to be in April. It'll be taking place here, right here in this room on the 19th. We don't know what sessions are going to be that, but I do know one of the sessions will be Tai Chi, because we did not get to experience that at the last day of renewal due to her being ill. So one session will be Tai Chi, just not sure about.
Recording in progress.
And then June 6th is our big 5K, hope for tomorrow. There's flyers out on the table over there. Feel free to take them, share them with family, friends, whoever you want to get involved. It's a big fundraising opportunity for us and a great chance to just get together with the community and share in the cause together. And then lastly, the next Let's Talk About It will be May 20th, and it's going to be a discussion on nutrition. So that'll be even exciting. So thank you all for coming. I appreciate it. And with that, I'm going to turn it over to Dr.
Yeah. Hi everyone, I'm Jordan Frey. Thanks for having me organizing this, and I apologize about last week, that last minute, like the virus ran through my whole family, so I appreciate your understanding. But I'm excited to be here and talk about breast reconstruction and sort of all the different nuances, and there's a lot of new things being done that's really exciting for me, and I think for all of the patients impacted by this. So I'll start with just a little bit about me. Was born and raised here in Buffalo. I'm married to my wife, Selmy, who she's actually from Miami. But I think she came up north first because we met at University of Rochester. We have 3 boys that are 7, 5, and 1. I ended up leaving Buffalo after high school. I went to in Atlanta for college, then Rochester for medical school, and then was in New York City at NYU for 7 years. And then after that, we were kind of figuring out where we wanted to be. And Buffalo was always, someplace we kind of had our mind that I wanted to come back to, and especially with, I knew I wanted to focus on breast reconstruction, and there was a huge need here, so I was really excited to be able to come back. So in terms of just how breast reconstruction works after breast cancer, or for someone undergoing surgery for risk of breast cancer, really it's an option after any sort of surgery to the breast. Whether we go through all the, whether that's like a partial mastectomy, a full mastectomy, a lumpectomy, any of that, there's always an option for breast reconstruction. And the other great thing about New York State is that there's a law that basically says all women who are having any sort of surgery to their breast related to breast cancer or risk of breast cancer are entitled to reconstruction, and that's covered by insurance. You are entitled to a consult with a plastic surgeon who specializes in breast reconstruction. And so that's a huge relief, usually for a lot of patients. The question that comes up, will this be covered by insurance? Is this considered cosmetic? It's all covered, which as it should be, but in New York State, it is law. And the other thing I'll say just at the onset, because this is a question I get from a lot of people, a lot of patients as well, is like, is there anything you can do? The answer to that is pretty much always yes. I can't imagine a situation where I would say, no, it hasn't come up with that, but there's always options to improve things. There's former reconstruction of some kind. So there's really no end of the road when it comes to breast reconstruction, which is also a nice thing. So I'll kind of go over for each, general broad category of the type of breast surgery we have and the different types of reconstructions available. And I'll say if there's any questions, definitely just interrupt, raise your hand or shout out a question as we go. So after a lumpectomy or like a partial breast resection or a partial mastectomy, those are all relatively interchangeable, but any sort of surgery to remove a breast cancer where you're not removing the entire breast, a lot of times that wasn't thought of as something that would require reconstruction after, but it definitely does. It definitely changes the shape and look of the breast and the symmetry. And after this, in most cases, radiation is required, which will also impact things. So more and more, we've sort of been able to get into the community and recognize the importance of reconstruction after these types of surgeries. And there's a few different options, which we'll go through. After mastectomy, which is more commonly what's thought of in terms of reconstruction, there are also options as well, which we'll go through, which are broadly kind of classified to like the implant type reconstruction and then autologous use of the tissue reconstructions. So after partial breast surgery or partial breast reconstruction, again, these can be done in an immediate fashion, so at the same time as that surgery, or in a delayed fashion, so after that surgery has already happened. And the first option that I'll talk about is called oncoplastic reconstruction. So this is kind of a broad term for any type of surgery that's using nearby tissue, so nearby skin and fat, basically to fill the area of the breast that had to be taken for the partial mastectomy or breast resection. And so this is really a great option for patients who say, yes, I have to have this tissue out, but I don't want to be smaller in size. I want to maintain symmetry. So we can do this. Is there a laser?
Yeah, hit the green button, right? Yeah.
So a lot of times the tissue we take is kind of from the lateral chest wall here, and it has blood vessels that it's attached to it. We sort of swing it over, if you can imagine, to kind of fill the hole that's created from the lumpectomy. And so this is an example in the operating room. So this was someone who it was really important. She wanted to stay the same size. She didn't want things to change after her surgery. He was getting a larger lumpectomy, so something certainly that if we didn't do anything, there would be a big contour abnormality there. So we found on this tissue here, where you see the dots, that's where the blood vessels are located. And so we sort of dissect this tissue and leave it connected to the blood vessels, and then move it over, and we're able to give that breast the same contour as the other side. We actually make it on purpose a little bit bigger than the other side initially, because the radiation is going to make it smaller in the long run.
Go back just a bit.
Yes.
So you're saying that first one, you remove the tumor, which is that hole, that's.
Correct.
So all you're doing is taking that tissue and you're laying it
And
over,
or
or
we're
you're sticking
swinging.
it in
Exactly. We're sticking it in like underneath
underneath.
that skin there.
Understood.
Exactly.
Okay,
So
thank you.
that it fills in that space.
Thank you.
Yeah. Another option, which is a really great one, when women undergoing lumpectomy or partial breast resection, is a lot of times there'll be women that'll come and say, you know what, I've always wanted breast reduction. My breasts have always felt large to me, and I have back and neck pain, and I either never got around to it, or I was worried insurance wasn't going to cover it, or something like that. Can you do that at the same time as the lumpectomy? And that's a really great option. That's called an oncoplastic breast reduction. And so essentially what that involves is the breast surgeon would remove the breast tissue needed for the lumpectomy. On that same side, I would do a breast reduction. And then on the other side, we would do a breast reduction for symmetry. So basically to get it to be the same size as the other one, so you're not left uneven or anything like that. Again, insurance by law covers both of those procedures. Again, you need radiation afterwards, and we know that most times. So the side that is getting the lumpectomy, we leave that one a little bit bigger on purpose, so that when the radiation shrinks it down a little bit, you have good symmetry. And this is really effective in providing very aesthetic breast reconstruction, but also alleviating the symptoms that patients have associated with larger breasts. And we can also do this. Sometimes there's patients who, for one reason or another, maybe they've lost weight, maybe they breastfed a number of kids, and they say, well, it's not necessarily that my breasts are super large, but they've dropped a significant amount. Can we kind of do a lift at the same time? And the answer is yes. Similar principle to here. So this is a patient who was undergoing this procedure. So on the right side, she was diagnosed with breast cancer. She had large breasts. She always wanted them to be smaller and lifted. So this is her afterwards, and after her radiation. So you can see we're able to lift them and get a nice symmetric result. The incisions are similar to a standard breast reduction, which are around the areola down in front of the breast and then underneath the breast, kind of anchor incision, we call it. And then another option is fat grafting. So this is basically a procedure where we take fat from somewhere else in the body via liposuction, and then we inject those fat cells into tissue somewhere else. And we do this a lot in breast reconstruction in general. After a partial breast mastectomy, again, this is typically done in a delayed fashion. So whereas the other ones were done immediately at the same time as the lumpectomy, this is usually done afterwards. Or a lot of times I'll see patients say, you know, I had my lumpectomy, I had the radiation already. I didn't really think or know of doing anything at the same time, but I have this asymmetry. What can we do? And this is really a great option in those cases. So this fat gets injected and helps break up the scar that's there. It helps fill that area of a contour of depression. And with the fat also comes stem cells, which have been shown to help reverse some of the effects of radiation and assisted healing and everything like that. And a very good question that often comes up is, well, does injecting this fat, does that increase my risk of breast cancer coming back or anything like that? Very, very good studies that I've been involved in and that other institutions as well have looked at. And the answer is no, it doesn't increase the risk of breast cancer coming back. Certainly if there was any risk of that or concern of that, we wouldn't do that at all. But thankfully it does not.
Is that just a one-time injection, or do you have to get it injected?
The one time in theory. So yeah, the fat that we inject, we know again via studies that about 80% is gonna survive. In a radiated tissue, maybe it's a little bit lower, like 65%. So we always overfill, knowing that some amount is gonna come down. Now, it depends on the amount of depressions. If some people will come in and it's a very significant, a lot of scarring, a lot of radiation damage. And I may say, I think we may need like 2 or 3 sessions of this in order to really fix this contour irregularity and get to the look that we want and the result that we want. But a lot of times we are able to do it in one session. This is like, it's an outpatient surgery. It's really, really well tolerated. Doing this alone, it usually is something that takes about 45 minutes or so. But it is a general anesthetic in the surgery.
Does the fat come back from where you pulled it from?
Dude, like, does it regrow like the belly?
Yeah.
No, you certainly can. Yeah, and then the joke is always, can you take a little extra? The answer is yes. It doesn't come back. If you gain weight, of course, some more will grow there, but it doesn't automatically come back or anything like that. So it is a nice little silver lining. The next option is what I call mini flaps. So this is usually for someone who is having a lumpectomy or a partial breast resection. And it's a larger cancer, something where we're kind of, with the breast surgeon, pushing the boundaries of what would need a mastectomy or not. And so you're moving a lot of the breast tissue, so much so that maybe the tissue that we have nearby to try and swing over would not even be enough. That's one situation where this is very useful. Another situation is in someone who comes to me has already had the lumpectomy and radiation, and it's a very, very significant defect in contour abnormality. And I say to them, you know, we could do fat grafting, but it's probably going to take 2 or 3 times. And they go, I don't want 2 or 3 surgeries. I don't want to be dealing with this for another, you know, year and a half or so. I just want this taken care of. And so we say, okay, it's a little bit of a bigger initial surgery, but we can take skin and fat from somewhere else on the body. Here it shows the abdomen, which is called a deep flap. Here shows the inner thigh. So this is a half flap that we have, you know, silly acronyms for everything. And so we take this tissue from this area, connect it to blood vessels, reconnect it to blood vessels in the chest, which gives that tissue life. And then we use that to fill that area and reconstruct the breast. This type of surgery, which I'll go a little bit more into during the mastectomy portion, but does require staying in the hospital for a few days afterwards, a little bit more of an involved recovery, but certainly a great option in these cases. That is after partial breast reconstruction. Any questions or thoughts or anything about that at this point? Before I go into the total breast reconstructions.
Actually, I have a
Yes.
question. How often are you seeing, people who are having, say, a lumpectomy come in and do some of those flap transfers, like from the get-go? Are you doing a fair bit of that?
More and more,
Okay,
yeah. It's
yeah.
not a super common thing, just
Right.
because in most cases, they're small enough that we can either use tissue nearby,
Yeah,
or it's someone who's like, I don't want to be bigger, I want to be smaller, and so
Right.
we're doing something like that. But I would say it's maybe like 4 or 5 times a year that we're doing a mini flap.
okay,
And that it has been a lot again with kind of getting to the community and talking to the breast surgeons and things like that. It was popularized by a guy named Joe Diane Memorial Sloan Kettering, who I was fortunate to train with, and so we've sort of been building it up.
yeah, I was curious too, just even about the, like, kind of bringing the same tissue on the
Yeah.
side around the first one you showed. Because I just feel like that, even I wasn't even aware that that was something that was happening
Yeah,
out there. a
Yes.
lot. I feel like so often lumpectomies can end up with, either, you know, if they're lucky, it's not a real noticeable, scar, but a lot of the time you get this deep fold or this deep indent, you know,
Yeah.
that it really is quite affected. And I just haven't seen a lot of, other than fat grafting, haven't seen a lot of plastic reconstruction for
Yeah.
lumpectomy.
Yeah, no,
Okay.
and those, we call them local flaps, the
Yeah.
one that are nearby. Yeah, it's similar, probably a little more common than doing like the free flaps.
Mhm.
And the real downside of that, the only downside is just that there's another scar on the side of the chest. But yeah, it's a really great option, and that, they do a lot in Europe.
Mhm.
But here, I think people are starting more and more to see the utility of it. And like you said, recognizing that after a lumpectomy, there is a defect, and even if it's not necessarily one you see on the outside, that what happens with that defect on the inside is it fills with fluid, eventually kind of gets walled and scarred off, and can feel hard and be uncomfortable. And so a lot of people come with that sort of sensation, saying that I really just want this better. Is there something we can do?
Thanks.
Any other questions? So after a mastectomy, so this is removing the entire breast. What are the reconstructive options? And I said before, they're kind of broadly categorized into implant options and then autologous, or using your own tissue options. And again, these can be immediate or delayed. So even if you've had a mastectomy and either at the time weren't sure if you wanted a reconstruction, or just didn't have it happen for whatever reason, you can still have a reconstruction. Probably 99% of mastectomies at this point, or reconstructions after mastectomy in patients who are electing not to go flat. We do in an immediate fashion. There's pretty much no scenario where I would see a patient who wanted an immediate reconstruction, say you're not a candidate for this one way or another. So implant breast reconstruction, within that bubble, there's kind of two options. One is using what's called a tissue expander, and one is using a permanent implant. I'll kind of go through that. So a tissue expander is, like, for lack of a better analogy, kind of a deflated breast implant. So what we do is the breast surgeon goes in, they remove the breast tissue, and then at the same time, once they finish, I would put in a tissue expander, generally on top of the muscle. There's two places you can put it. You can put it on top of the chest muscle or below the chest muscle. In general, I think on top of the muscle is better. It's less pain, a quicker recovery. It looks and feels more natural. The biggest downside of on top of the muscle is sometimes you can see the ripples of the implant a little more prominently. And that's where fat grafting is really a benefit. So doing that afterwards can improve that significantly. Under the muscle is really reserved for people who are more high risk with implant reconstruction and maybe not a candidate to use their own tissue. So someone like a smoker or something like that, just because that muscle gives an extra layer of protection for that implant or tissue expander. So the tissue expander itself, we would put in at the same time as the mastectomy, generally on top of the muscle. We'd fill that partially with saline or salt water, and then close everything up. And you'd have it drain, stay overnight in the hospital, and then generally go home the next day. Once we were having you in the office and the drain come out and the dressings were off and everything like that, we'd fill that expander with more saline or salt water. And that's a procedure we do right in the clinic that takes about 5 minutes. It's painless and really pretty straightforward and well tolerated. And then once that tissue expander gets filled to the right size for you, for your body, say, okay, we're not going to fill it anymore. We're going to give it a little bit of time, usually a couple months, and then we're going to do another surgery where we go back to the operating room. We use the same incision to open things up, take out the tissue expander, and put in the permanent implant, which there's two varieties, silicone or saline. Silicone's more commonly used just because it feels and looks a little more natural, and it's actually lighter than saline. So with the tissue expander, it's 2 stages and requires 2 surgeries. There's really only 2 scenarios where a tissue expander is beneficial. Because most of the time I'll say, well, you can do this temporary tissue expander that requires 2 stages, or we can do the implant right away in 1 stage. And people just go like, well, why the hell does anyone do a tissue expander?
You have an answer for it.
Yeah.
The one reason is sometimes patients will come to me and say, look, I've had smaller breasts my whole life. I'm going through this now. I want larger breasts afterwards. Tissue expander allows you to grow more skin to accommodate a larger implant. So that's the reason for the tissue expander. The other reason is, if you can imagine, when the breast surgeon's going in, they're removing all the breast tissue, but they're leaving most or all of the skin on top. As part of removing that breast tissue, they're also going to remove a lot of, not all of, but a lot of the blood vessels that supply blood to the skin. So we're always really cognizant and aware of the health of that skin over top. If the skin at all looks questionable, the safer thing to do is use the tissue expander. Because I can put that in behind the skin, drop that, and just not inflate it, and let that skin heal first, and then inflate it in clinic. Once it's all healed, then I'm not worried about any wound healing issues or something like that. With an implant, if I put the implant in, it's just a fixed volume, so it's going to put a fixed amount of pressure on that skin. And if the skin is a little bit compromised from just the mastectomy, that can be enough to lead to a wound healing issue, which can lead to losing the implant, which then, you know, puts us into a place where we don't want to be. So that's where tissue expander is safer. Now, I will say, especially the breast surgeons I work with, are really, really fantastic at maintaining the health of that skin. And so 99 times out of 100, if we go in saying the goal is to do an implant right away, we're able to do that. I still tell people, listen, there's a chance in there we may make an audible if things don't look perfect. But that's rarely, I think here in Buffalo, I don't know that I've had to do that, but that's something that's always, we talk about.
How does radiation play into expanders?
Expanders versus implants?
Yeah, like, can you,
Or-
because I feel like I've worked with people who go through this, so.
Yeah.
So I tend to see expanders more often than direct to implant.
Yeah,
And sometimes I feel like their understanding of why is because they were told they had to have radiation. And so if that was the case, then they needed to have, an expander.
first.
Is that typically what you would see as well?
I'm the opposite.
Okay.
So there's a lot of different literature out there
Mhm.
looking at if you know they're gonna need radiation, should you put a tissue expander in first, then go to an implant after radiation, or put an implant in first and then do the radiation? What the data has shown is if you put the tissue expander in first and then do the radiation and then put the implant in,
Mhm.
your aesthetic results are maybe a little bit better because you kind of get a second chance to go in and maybe, adjust things a little bit. But your risk of complications is way higher because you're going back and doing a second operation on tissue on breast that's been radiated. Also, that data came out when a lot of people were doing reconstructions underneath the muscle.
Okay.
And they were getting a lot of what's called capsular contracture, or a lot of really dense scar tissue around the implant. And what we've kind of found out as we started doing more of the reconstructions on top of the muscle is that it wasn't really the implant's fault that was happening, but it was just that muscle was getting really fibrotic or scarred from the radiation and causing a lot of that contracture. So for me, actually doing the reconstructions on top of the muscle, that has made the aesthetic results, be a lot better. And quite honestly, a lot of times patients who get radiation after their immediate implants, they tell me they like the radiated side better because it almost gives it a little bit of a lift. And sometimes we're going back and lifting the other side and trying to match that to the radiated side. And you have less complications. So radiation wouldn't make me necessarily do one or the other. It kind of would still be the other factors of the size you're going for and just the health of the quality of that skin.
If you put the implant underneath the skin or on the muscle, what holds the implant there? I always want to put it in the muscle.
No, it's a good question. So what holds the implant there? I'll get to that.
Okay.
These are just examples of some patients that had tissue expanders and then after their exchange to an implant. So in one stage of reconstruction. This again is with where we put the implant in right away. It's theoretically one stage. I do put an asterisk there. So when I think I've studied about it, but when I was at NYU, we did a study looking at patients getting nipple sparing mastectomies and implants right away. We pointed breast in a day, and it got really big and picked up by NBC and stuff like that. The thing though we always had to kind of put an asterisk next to is we did do a study and looked at okay, how many surgeries do patients actually get who are getting this breast in a day versus those who are getting a tissue expander. And the tissue expander patients averaged about 3 surgeries, so the 2 and then a revision. With the breast in a day, patients still averaged 1.6 surgeries. So there are still patients who are getting touch-ups and things like that. So I always still say, yes, you'll come out and you'll have your breasts just like you went into surgery with them. But you may still in the future elect to have another surgery. So it's not necessarily a one and done. So that's always my disclaimer. So again, like we talked about, depending on the quality of the skin, there's always the chance of adjusting to a tissue expander or operating room. That's rare, but something just to keep in mind. Yes. These are just some patient examples here, and then I'm getting to your question. So you're totally right. If we just put an implant in on top of the muscle, it would basically just slosh around. It wouldn't stay in the right place. Tissue expanders have little tabs on them that we can sew down to the chest to keep them in the right place. And then when we put the implant in a second stage, there's enough scar tissue formed around it that it holds it in the same place. But we don't have that when we're doing an implant right away. So the traditional option was putting it under the muscle. This is an example of putting it totally under the muscle. This is an example of putting it partially under the muscle. So we have it under the pectoralis muscle up top, and underneath is what's called an acellular dermal matrix. This is acellular dermal matrix is basically just a fancy catch-all term for any sort of biologic material. So something that used to be skin on something, whether it was a human, a cow, a pig, something like that, that has by a company been decellularized, so it no longer has cells on it. It's just like an acellular scaffold, and we put that in and use that to hold the implant in the right position. So in doing it on top of the muscle, this is how we do it. We basically wrap it with this acellular dermal matrix here, and then we stitch it into the chest wall to hold it in the right place. This is something that has been really well studied and shown to be safe. It's not, people ask like, well, could my body reject it? The answer is no, because it has no cells on it anymore. It's been completely decellularized. This also has gone through tons of iterations in terms of the product. The initial product, and this was probably like 10 years or so ago, was very different. It was not, I don't know the right way to phrase it. It was aseptic, but not asterile, which is basically just this, like a definition type thing. But it led to more infections and seromas or fluid collections. So for a long time, we just didn't use it at all. And then they started making them thinner, and they put holes in them, and they changed the way they sterilized it. And so we've done a lot of studies looking at the safety profile, and now it's actually shown a safety profile that is the same or better than under the muscle. And has actually been shown to, again, reduce pain, improve recovery, reduce the need for pain medication after surgery. So a lot of advantages to it. But that's how we hold it in the right place. Any questions about implants before I talk about autologous? Yes.
I'm curious about the life of the implant. What's the need of the saline or the silicone? Do they both have the same?
Yeah, good question. So, and then I'll go over that. That's a good point. I'll kind of go over the main benefits of using an implant are that it's a pretty like straightforward surgery. It's the surgery itself, along with the breast surgeon. Usually, like today, I did one with Dr. Furstenberg, who's a fantastic breast surgeon, but it was for two sides with immediate implant reconstruction. It took us about 2 hours in total. So it's a relatively quick procedure, a straightforward-ish recovery. You would drain in each side. You're in the hospital one night until you are back to like no restrictions or anything like that is about 6 weeks. The main downsides are it's a foreign body. So there are always risks with that, whether it's a knee replacement or a breast implant. And that's just that there's increased risk of infection or wound healing problems. Now, where a patient lies in that risk spectrum depends on a lot of things, like do you have risk factors like diabetes or smoking? Are you planning to get radiation or chemotherapy? Have you had radiation or chemotherapy in the past? Those all play a role into that. But in appropriate selected patients, they're very, very safe. In terms of the lifespan, the FDA says that a breast implant lasts 10 years. And that's obviously an estimate, but it's probably a pretty good one. But that's another downside, especially if there's younger patients that come, look, a few times in your life, you're going to have another surgery to have these implants exchanged. It's not like at 10 years, we call you and I'm like, oh, your warranty's up, come on, change it out. But if something happens, then we need to do something about it. And what could happen? The biggest things are implant rupture. malposition, meaning it changes position, just doesn't look right. Or capsular contracture, which again, when that scar tissue around it becomes tight and uncomfortable. And I know people had implants for a lot longer than 10 years, no issues. I've had patients who had them for a lot shorter and had something that we had to do. So I would say 10 years is a pretty good estimate.
And it
And
doesn't matter.
saline or
silicone
silicone are similar. Yeah, exactly. Other big, another big risk that was talked about with implants in the past was breast implant associated lymphoma. I don't know if any of you are familiar with that. So there were two different types of implants. There were smooth implants, which is like the one shown here. You can kind of see on the back side, the surface is just smooth. You can kind of see that. And then there were textured implants, which had like a rough texture on top of them. Textured implants, ultimately, it was kind of found out and shown they were associated with this indolent, like really slow growing form of lymphoma. Very rarely, but in certain cases they were, and you would have to take it out. And it was obviously a very scary thing for someone who's already gone through a cancer experience. Those implants are not used, should not be used by anyone anymore. In general, I think the smooth implants, it's what I always used anyway, just because I think aesthetically they looked a lot better. But with those, they have not been associated with this at all. It's still something obviously we keep an eye on and are cautious of, but it's not something, like I would feel very, very comfortable with my wife, you know, having implants, whether they're silicone or saline, or anything like that. But that's a question I think a lot as well. So using your own tissue. So we call this autologous, or more commonly like flap reconstruction. So this is basically where we take skin and fat from somewhere else on the body and then transplant it to the breast. Where we can take it from, a lot of different areas. The most common is definitely the belly, and that's the deep flap that you may hear about the most, which just stands for deep inferior epigastric perforator flap. The second most common place is the inner thighs. Here it says tug. That was an older option where it would take muscle with it. Now I use it, it's called a pat flap or profound artery perforator. That's kind of getting into the technical weeds, but it just comes from the inner thigh. So it's like a thigh lift type incision. After that, the next most common is the lower back, the lumbar artery perforator flap. And you can also take it from the butt. That has kind of fallen out of favor just as the aesthetics of the day. People kind of want to maintain their butts. So basically what we do is we take the tissue from this area, the skin and fat. It's attached to a blood vessel. We disconnect that blood vessel wherever we're taking it from. So let's say it's the belly. We disconnect the blood vessel in the belly, reconnect it to blood vessels in your chest, and then use that tissue to sculpt the new breast. This is another instance where it's with an asterisk, a one-stage reconstruction. There may be revisions in the future, but sometimes patients go, no, I'm happy, this looks great, and there's no need for anything else. It's great, especially for women with larger breasts, where implants don't do as great a job with a reconstruction, just because there's a limit of how big implants are and things like that. It's also great for people who are going unilateral, so one side mastectomy. The implants, one of the toughest things I have to do is match a natural breast to an implant. Getting two implant reconstructions to look really nice is more straightforward, but getting one to match the other is tough. Doing that with your own tissue is a lot easier. And it works for patients with smaller breasts as well. So again, these are some examples. So this is, again, where this tissue, this would be a deep flap, so the skin and fat is connected to a blood vessel here. We don't take the muscle. So there used to be that you would take the muscle with the skin and fat. Now we don't do that at all. You don't have to take the muscle with any of the options that I discussed. So it's a lot more easier in terms of recovery. You don't lose the function of that muscle after the surgery like you would if it was transferred. And then like in the belly, you end up with a tummy tuck incision. the inner thigh, you end up with a thigh lift incision. And so this is myself and my partner, Dr. Guy. This is how we sew the blood vessels together under the operating microscope. And this is an example of a patient who had that surgery after her procedure. These are some other patients. This patient had a breast reduction first. She was a prophylactic case, so she had a breast reduction first and then underwent autologous reconstruction. And then another example here, these are all different patients. So this is someone who had a bilateral reconstruction. She elected not to have nipple reconstruction. This is someone who had a unilateral reconstruction. So this is a breast that did a reduction on to match this one, which she had a deep flap, and we were doing nipple reconstruction here. You can see here her tummy tuck incision. And then this was someone who had a bilateral reconstruction, taking the nipples. Most patients I try to convince, like, let's make this circle smaller so that it fits the tattoo. She was like, I don't want another operation, just put the tattoo on anyway. So my PAs in the office are trained in new 3D nipple tattooing, so this was an example of them doing that. So this is a patient again. Sometimes there are patients who are very skinny, don't have a lot of tissue, and say, I will not use implants. I want to use my own tissue. In those cases, we have options, which we call it a 4-flapper. So this is where we do, we use the abdominal tissue and the inner thigh tissue at the same time. It's definitely a bigger surgery, and you're obviously healing 3 areas at once. So not something to be taken lightly, but something that's very effective for patients who want that type of reconstruction. A lot of times I'll see patients who have implants and they're not comfortable, or they don't like how they look, and they want to change to a flap reconstruction. So that's probably one of the more common surgeries that I do. So this is an example of a woman who had a unilateral reconstruction. So one side, she had an implant and then got radiated. And then she came to me saying that she wasn't happy. This was very tight and uncomfortable, and wasn't sure what her options were. So we ended up removing that implant as well as all the scar tissue on the inside. And we had to use both sides of her belly to reconstruct the one breast. And so here you can see we did a reduction on the other side, or more of a breast lift on the other side to match it. This is what she looked like. She decided again she didn't want nipple reconstruction, but a much more comfortable and symmetric result for her.
Did she make the decision to have the one-on-one?
To
Well, after she realized what it was and she wanted it changed, would
Yeah.
she have made that choice?
that she to change it out.
No, obviously she made the decision to change it out.
Yeah.
But it was her decision initially to have the surgery with the implant, correct? Because I'm just wondering, why would she go through it again? Did she flip a coin and it came out?
He was one that he wasn't offered anything other than. Yes.
I have implants.
Yeah.
I have one really lovely, they're great. Dr.
Yeah.
Kirstenberg speaks really highly of you.
Yes.
Yes, and so does Dr. Singh, by the way. I have implants.
Yeah.
We're talking about doing this flap surgery on the one side that was radiated.
Yeah.
Would you do both, or would you just do the one?
It really depends. If some people are like, just do both because I don't want to have to worry about one side or getting one side replaced in the future. And
This side's really good. It's the side that was radiated, that's tighter.
you don't
than
have
me.
to. I've had patients who say like, this one's not broken, don't fix it. I
Okay.
don't want to mess anything. The only thing I tell them is like, so when let's say we did one side, so we would use one half of the abdominal tissue for the one side reconstruction. We don't leave the other half of the abdominal tissue on because you look really lopsided.
Thank you.
and funny. We just remove it. So that's not available. Let's say in 10 years or something happened, you go, you know what, just get rid of this implant. I had an issue with it. We don't have that tissue available. Now we have it from other areas that we can use. So that's why I tell you, just understand that this option is available for that. But no, you definitely don't need to. Nipple reconstruction I put here briefly just because I get asked about it a lot. There are two different options for nipple reconstruction. One is where we actually can use some of the tissue that's on the breast to make a new nipple that projects out, that actually sticks out. And then we tattoo the areola and nipple around it to give it a color. That surgery to make the nipple that sticks out, it can be done at the same time. Let's say you're going for fat grafting or something like that, you can do it at the same time as that. If you're only doing nipple reconstruction, then it's something we can do under local anesthesia right in our clinic. The tattoo is done in the clinic as well. And the other option is just a 3D tattoo. So it's a flat tattoo, but it gives the appearance of the nipple projecting out. That's something my PAs do. They've gone through a bunch of courses and do an amazing job of it. So it's really just a preference. Some people are like, you know what, it's kind of nice. I can always just wear a shirt without a bra and not worry about things sticking out. Other people, it's really important to have something there. So it's a very personal thing.
My question was just gonna be, does insurance cover nipple reconstruction
Yes,
in your
and
office?
tattoo, yes.
And tattoo?
Yeah,
Okay, cause I know, like, for example, there's certain tattoo artists that specialize in
yes.
doing this, but they don't always accept insurance.
Yes, no, our office, it's all through insurance.
Okay.
I was told by mine that if it's done in a medical facility, they'll cover it.
Yeah.
But if you go somewhere else, it's not covered.
Right.
Okay,
So if you go to a medical with the hospital, they'll
Yeah.
cover it for you.
makes
Yeah.
sense.
And there's awesome tattoo artists in the area that do it. And our PAs are fantastic as well. So a lot of people will go and see it for consults and stuff to get a whole picture of what we can show them. Nipple sparing mastectomy, I'll mention this briefly. This is something that's become more and more popularized and it allows for saving the nipple at the time of mastectomy. The decision is a decision that's made in coordination with the oncologic breast surgeon. So the way I always put it is both of us have to say yes, that it's possible. But if the breast surgeon says no, they have all the veto power. Because if there's any oncologic concern that they have, that takes precedence. Now, there's lots and lots of studies that have shown that nipple sparing mastectomy, the rate of recurrence of breast cancer coming back is the same or even slightly less, but not statistically different. So basically the same as a surgery where you remove the nipple. But obviously you get improved aesthetic results, and as good as the nipple reconstructions are, you know, keeping it is definitely a great option. This also, like I said, gives the potential for the breast in a day surgery. Here's some. There are certain cases where even if, let's say, the breast surgeon says, you know what, it's definitely, we could save the nipple, where I'll talk to patients and tell them, you know, yes, we can save the nipple, but aesthetically, it might actually look better without the nipple. And the reason for that is especially in patients who are have really, really large breasts, or a lot of breastosis, meaning that the nipple is kind of dropped very far down on the breast. Because in that case, when you do the reconstruction, a lot of time the reconstruction can end up really high and the nipple can end up really low. There are things we can do, like a stage procedure, like I showed the one patient, where you stage, you do a lumpectomy and a breast reduction at the same time, then let that heal because the cancer is out, and then you do a mastectomy and the reconstruction. But if we're trying to do it all in one, in a lot of those cases, taking the nipple actually can work a little bit better. I put this up here. This is just a website if any of you guys are interested for additional resources. This is something when I was at NYU that we built, and we built a whole risk calculator for breast reconstruction, but especially breast reconstruction after nipple sparing mastectomy. And so there's a lot of good resources there. The last kind of thing I'll talk about is kind of the newest thing that we're doing and I'm really excited about, and that's nerve resensation. So just like I was talking about, when the mastectomy is done and out of necessity, the breast surgeon has to remove a lot of the blood vessels that supply blood to the skin. He or she also has to remove a lot of the nerves that supply sensation to the skin. So after a mastectomy, patients, their breasts were numb. And this was kind of just, an accepted thing for a long time. Now, I'd say it's really been gaining popularity probably for the last like 7 years. In the last 5 years, we've been doing it here and having really good results, is this breast resensation technique. So basically the way it works is it's in conjunction with the breast surgeon. They do what's called a nerve sparing mastectomy. So they're gonna do the mastectomy and they're gonna find the nerve that runs from the side of the chest up to the nipple. Now they're gonna have to remove the part of that nerve that goes through the breast, just because that could be impacted by cancer either now or in the future. But they're gonna preserve the part that's not. And then what I do is I do the reconstruction. It can be done whether it's an implant or your own tissue. And then I use a nerve graft that comes off the shelf. So this is similar to that acellular germinal matrix I was mentioning. So it's a nerve from a donor that's been completely decellularized. So it's not like a transplant where you're like rejected or anything. It's just a scaffold to help that nerve grow. And I connect that from the nerve that's in the chest. So you can kind of see it here in this picture. So the nerve in the chest, there's a connection there. Here's the nerve graft. And then underneath here, it's connected to a nerve underneath the nipple. And that allows the opportunity for sensation to come back after the mastectomy. Now, nerves in general grow really slow. They grow like an inch a month. So it takes 6 to 12 months for the sensation to come back. It's rare. I have maybe a couple patients who would say 100% of their sensation came back, but even I would challenge that. It's usually not all of it comes back, but some of it comes back. But it's been a huge difference maker for my patients for sure. It's also like, I would say it's very rare that there's like a free lunch in surgery. But this is kind of a free lunch. It's something that is covered by insurance. It doesn't increase the risk of the surgery at all. It's not like there's increased risk of infection or the reconstruction not working or anything like that. And it takes maybe per side an extra 25 minutes or so. So it's not like it's prolonging the surgery a long time. So it's a pretty free thing. I always say, we've had really good results and I would expect it to work. If it doesn't work, we're just in the same situation as if we did nothing. So it's worth a shot. I have done it in patients who have already had their mastectomies and come afterwards and said, I didn't know this was an option. Can we still do it? And I've done that. The results are a little less reliable just because you're dealing with more scar tissue and things like that. But have seen some nice positive results. So you can do it even if you've already had the mastectomy.
How big is the nerve?
It's like 1 to 2 millimeters thick. So it's pretty thin. It's like an angel hair pasta.
Wow, so you can actually see it.
Yeah, we use the loops, magnifying glasses and stuff and really small stitches. Oh, I talked about any questions about that, I guess. I know we didn't sit on it.
You just take one nerve for.
It's usually one nerve. Yeah, sometimes we'll get lucky and find two and we'll kind of like wire the two nerves into one nerve graft to kind of maximize, but in everybody, there's one main nerve, the fourth intercostal nerve that innervates the nipple, and we try to get that one. And there's been good studies showing that afterwards, it doesn't just re-innervate the nipple, and it re-innervates the rest of the breast as well. So that's kind of the main one we focus on.
Branch off? The one nerve branch off or no?
No, it really just kind of goes just to
one
the
side.
nipple, and then we'll branch out there.
So kind of my question is, can you do the nerve resensation even like say without, non-nip sparing?
With non-nipple sparing.
Is
The
it-
answer is yes.
Okay,
There's not really good data out there
Okay.
yet of like how well it works and stuff.
yeah,
So when I tell people, I basically tell them like, I don't know how this will
Yeah.
work or what results you'll have. But again, I generally think it's worth a shot.
cool.
Yeah. Yes.
Is there like any kind of painful sensation where the surgery was done to the nerve?
Where it was.
I mean, like, you're like, oh my God, my nerve, this is killing me, like. Do you get
Not
this, do you feel?
with this,
Yeah, when you're
usually
doing
not.
the nerve like, like a nerve implant or
Yeah.
whatever.
No, usually not. This is actually something, I've had some patients who have come and said, after my mastectomy, I have like right here, and they can point to it, a ton of pain. And usually what that is that's a nerve that's been cut and formed what's called a neuroma, which is like a little scar cap on top of the nerve. And the reason that is because that nerve that got cut, it didn't have anywhere for the nerve fascicles to grow. And so it causes this just big painful scar wall. In these cases, when that happens, what I usually do is I'll go in, find where that neuroma is, cut it out, and then connect it to a nerve graft. Because then those fascicles have somewhere to go, and it's like nerves, we learned a lot of this from hand surgery. But nerves, when they have somewhere to grow towards, they're happy and they don't cause pain and things like that. So this, knock on wood, I haven't had anyone have any issues with pain or symptoms like that after this type of surgery.
So this actually even has, I mean, based on what you just said, this has the potential to even reduce the amount of pain, for like nerve
Yeah.
following.
Yeah, or definitely reduce the
The
risk of
potential
neuroma.
for, yeah, okay.
And you can be like a couple years out from original mastectomy?
Yeah, again, it's similar in those situations. I always say like, we don't really have good data. With doing it at the same time, I can tell you pretty good from national data, like what to expect. In a delayed fashion, we don't have that yet. But I know a lot of people who do it and have anecdotally good results, and I've had so far. So it's something I'm very comfortable offering, and I think it helps and is worthwhile. Talk briefly about lymphedema, just because this is something that also is, I think, finally becoming more recognized as an issue after breast cancer treatment. And there's lots of things that we can do to help it. So with lymphedema, there's kind of like two modes of treatment. One is conservative treatment, which is always the first step. And so that's things like a compression garment, a pneumatic pump, which is kind of this like spaceman pump you put on, and it like inflates sequentially to help remove fluid from the arm. And also lymphatic therapy, so going to like a physical therapist or occupational therapist who focuses and specializes on lymphedema. Those are always the mainstays. And that will, a certain subset of patients who develop lymphedema after breast cancer treatment, that will actually cure their lymphedema. But there's some patients who will do all that and still lymphedema is either staying the same, maybe not getting worse, but not getting better, or getting worse. And that's then when the patients come and see me and we talk about the surgical options for treating lymphedema, of which there's kind of three main treatment options. One is called a lymphovenous bypass. The other is a vascularized lymph node transfer. And then the other is liposuction. So the way lymphedema works is basically all of us from the tips of our fingers going up our arm and then emptying into our heart, we have lymphatic vessels. And their job is basically to take excess fluid and drain it. With any kind of breast cancer treatment, even if it's just on the breast, but especially if there's any sort of lymph node work done, whether that's a sentinel lymph node biopsy, an axillary dissection, or radiation, that can damage that kind of flow of lymph fluid, and there basically becomes a roadblock somewhere in that pathway. And then you get fluid buildup. That causes inflammation, which causes scarring, which causes fat deposition, which causes more blockage, causes more fluid, and then it just becomes a vicious cycle. So our surgical options are kind of aimed at treating that. So the first and probably most common is what's called lymphovenous bypass. So essentially what we do in that case is we find wherever there's a blockage, let's say it's like right here in your arm, and we make a little incision. And with the microscope, we find where that lymphatic is. We divide that lymphatic, so here, see there's this lymphatic here, and then we're going to reconnect it to a vein. So this is the presentation, I'm sorry, the pictures are kind of dark. So we've connected those lymphatics into a vein. And that allows that fluid to now have like kind of a detour bypass around that blockage. It goes into the vein and back to the heart, it gets recirculated, and the system is kind of restored. This has been shown to be really effective. About 80% of patients who have lymphedema and have this surgery see a positive improvement in subjective symptoms and in reduced size and circumference of the arm. The goal is eventually to get to a point where you don't need that other stuff, like the compression garment and the pump and things like that. Now, in some patients, the lymphedema is going to be so advanced that the lymphatic is damaged all the way throughout. So there's no part of it that's working that we can bypass anything to. So in that case, what we have to do is bring healthy lymph nodes from somewhere else in the body to that arm. The last thing you want to do, however, is steal lymph nodes from somewhere else and then get lymphedema there. So the most common place that I take them from, pretty much the only place I take them from, is actually from inside the belly. So there's lymph nodes that live kind of around your intestines. And basically that's what's pictured here. It's called the omentum. But you kind of use a little incision above your belly button. You harvest this tissue along with blood vessels, and then you reconnect those blood vessels to blood vessels in the armpit, and then usually in the wrist as well. And what that does is those lymph nodes heal there. They soak up that extra tissue, and they also help generate and grow new lymphatic channels that are going to help drain that tissue as well. The lymphatic bypass, lymphovenous bypass, is a surgery that's like an outpatient surgery. You're essentially back to your normal life like a few days later. This is definitely a bigger surgery. This is a flap surgery. We're transferring tissue, we're transplanting tissue. So you are in the hospital for 3 days afterwards. I should have said that with the autologous reconstruction for the breast. You're in the hospital for 3 days afterwards as well. And for both these, the reason you're in for 3 days, you're not like in the ICU or laying in a bed or something like that. It's just we're monitoring that tissue to make sure it's healthy. Our worst fear is that something happens to those blood vessel connections and that tissue isn't getting blood flow, in which case it would die. That's very rare, but that's like what keeps me up at night. So we're monitoring that. We're making sure it's all good. If something is going to happen, statistically, 90% of it's going to happen in the first 24 hours. By the time you're going home after 3 days, we're going, this looks perfect. Go home and don't worry about a thing. But that's why after this, you're in the hospital for 3 days. And then you're on arm precautions for like 6 to 8 weeks. So like no heavy lifting, no strenuous activity with that arm. I don't have a picture, I guess, for like liposuction is the last one. So liposuction is kind of serves two roles. So whereas these first two procedures are going to address the root cause of the lymphedema, which is the lack of that lymphatic flow, the liposuction is not going to address the root cause. It's just going to address the symptom, the extra fluid and the extra fat that builds up. So it's generally reserved for patients who just have really, really bad lymphedema and are not good candidates for a vascularized lymph node transfer, or they just go like, honestly, I'm not up for that surgery. That's too much for me. So then liposuction is a great option. It's also a good option for patients who, let's say they've had a bypass or they had a lymph node transfer and they go like, you know, my arm, it reduced in size by 50%, but if we could just get it that last 10%, that would be amazing. Liposuction is really good at kind of assisting with that. It's not a permanent fix, except in the case of where it's being used as like an adjunct to the bypass or the transfer. But if we're doing liposuction alone, it's not a permanent fix, but it is long lasting. It lasts generally around like 10 years or so. So it gives a long time and it's really effective. And that's also, it's not an easy recovery because it's a lot of, we bang up a lot, but you're kind of back to your usual activities and stuff within like a week and a half or so. With that, I just have knowledge. It takes an incredible amount of teamwork, and I'm really proud of the team that we've built at, you know, with ECMC and with the Clyde system and sisters and everything like that. Especially like at ECMC, we have a whole breast reconstruction floor. The patients go to in a private room, and our nurses are just amazing that I've trained and worked with for so long. But it truly takes a team, and there's a lot of amazing people that I work with that make all of this happen.
Can I back to one question?
Yes.
The flap surgery, how long do you have to stay in the hospital for flap surgery?
3 days.
3 days?
Now, I have some people who like on the second day are like, just get me out. And that's okay on a case by case basis, but usually the third one we go.
Okay, and then how long you usually gotta work for?
Depends what you do.
Floral design.
I would say,
I don't know what you do. I'm up and down.
yeah, well, I usually.
It's not a week.
But it's not a week. I mean, there's a spectrum of recovery with the flat surgery. I've had some patients ask me like, can I go skiing a week later? And no, the answer is no. And then I have some patients who it'll take, I usually quote and say, no restrictions, like you go run a marathon 6 to 8 weeks. And some people will take up to that. Something like that is kind of up to you. I would say, tell yourself 4-5 weeks. You may after a couple of weeks go like, oh, I'm kind of bored. I wouldn't mind going and doing some stuff with my hands. And other people are like, no, I'm not bored. So it all kind of depends. Put around there.
Okay.
Yeah. Any questions?
I do have a question about if you've already had the implants and whatnot, and you've had the
Yeah.
radiation. And then there's issues with it, it's tight, things are not working,
Yeah,
but you've had an issue with that side already, where there was rejection, there was a second surgery, things like that. Is there an issue with rejection on this, with doing the flap, taking your natural?
No. Good question. The answer, radiation does increase, it doesn't, so again, getting technical, like the study show, radiation doesn't necessarily increase the risk of the flap not working.
Mhm.
It does increase the complexity of it. It's definitely more challenging. The surgery might take a little bit longer. It's just a little more meticulous. The vessels are more damaged and friable, so we have to be extra careful with them. But not an extra risk of like this not working at all.
Well, I get an infection after my surgery.
That's okay.
So I was supposed to get my implants that day and I didn't.
Yeah.
I had implants or expanders.
Yeah,
And then I had to have them out because I had an infection in the one we're talking about.
yeah,
So 5 surgeries later, we're just
Yeah.
debating on what we should do.
yeah. No, that's definitely, it won't increase the risk again
Okay.
of this not working or anything like that. That's a good reason for this,
Mhm.
to kind of be a backup when the implants don't work. Thank you, guys. I appreciate your time.
Wait,
Yeah.
sorry, I was just chatting with Amy before. We both work with survivors a lot and just wanna make sure we're aware of all the resources. And she mentioned that aesthetic flat closure is really a specialty in itself.
Yes.
And I just wondered if you'd comment on that.
Yeah, no, it's definitely,
Yeah.
I would say in the relative, in a lot of ways, it's almost trickier because you
Yeah.
kind of want to get things just right, get the scar in the right position, and we can
Right.
get the extra skin and everything like that. So yeah, that's definitely something that we work with breast surgeons on a lot, and like at the same time as mastectomy to do that.
In other words, that you would team up with a surgeon who's treating the cancer.
Yes.
And they would not be expected to perform this. You would be there to do that?
Yeah,
Okay.
yeah, there are sometimes the breast surgeons are like, I feel really comfortable doing it, and they do it themselves. Sometimes if it's maybe more complicated, they'll ask me for my help as well.
Yeah, well, having run support groups over many years locally, that used to be a frequent complaint.
Yeah.
That people were not happy with their results.
Do you do any flat closure?
Yeah,
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 Okay.
cool, okay. Yeah, because that is something I've seen too, where, locally, I know there's surgeons who have seen great results from what I would call aesthetic flat
Yeah.
closure. I've also had people who surgeons said, oh, we don't need a plastic surgeon, I can give you what you want, and it is not what anyone would call aesthetic flat closure.
yeah,
But they were kind of, so I'm glad to know you do that
yeah.
as well.
Definitely.
Great. Great.
Thank you so much.
Yeah, of course.
Yes, thank you.
This is my cell phone, this is my email, if you guys ever want to contact me or anything, I'm happy to answer.
I'm calling you tomorrow.
anything.
I got your business card from Doug, I was saying.
Oh, perfect.
Okay. Dr. Singh and Dr. Furstenberg, I saw her last week and she said, I can do tomorrow.
I know, I was just with her, I was with her on Monday and then today.
Yeah, she said, he didn't tell me anything about this, and it got canceled.
But that's what I know,